All right, so thank you all so much for joining. We'll go ahead and kick off our call today. It is 1 o'clock. So welcome back to March APIC Great Lakes Education Webinar. We're really glad you were able to carve out time to join us today. So my name is Kelsey Ostergren, and I am joined by Chow Win. And I just wanted to take a moment to introduce Denise Parr, who's actually the newest member of our APIC Great Lakes Education Committee. Our team really wanted to make sure that we can continue providing the highest quality of educational programming for all of our members. And so to be able to do that, we've expanded our committee to meet those needs. We are thrilled to be joined today by Margaret Sturgis for her presentation titled Preventing MDROs in Nursing Homes, Enhanced Barrier Precautions. And so before I turn it over to Margaret, I just wanted to go over a few housekeeping announcements. If you can please mute your line, that'll just help minimize some of the background noise. As always, please feel free to use the chat to drop in any questions you have during the presentation, and we will circle back to all of those at the end. And as always, we are recording this presentation, which will be posted on our APIC Great Lakes YouTube channel, and we will also post the slides from today to our APIC Great Lake website. So you will have all of this content. You can download it, save it for your reference, send it to a friend, whatever you want to do. And lastly, just a note for today's session, we are not offering CEs for this webinar. So just wanted to make everyone aware of that. So with that, thanks again, everybody, for joining. And Margaret, welcome. Thank you so much for being here, and I will turn it over to you.
All right. Thank you. I'm going to go ahead and share my screen. All right, can you see my slides okay?
We cannot.
You cannot. Okay, give me a sec. How about now?
Now we can.
Oh, good. That had me scared for just a minute there. All right, well, thank you, Kelsey and APIC team. Thanks for having me join this educational session today. I am really excited to have this opportunity to talk with you about enhanced barrier precautions in nursing homes and how they can help prevent MDROs. So MDROs is an umbrella term to denote microorganisms, predominantly bacteria, that are resistant to one or more classes of antimicrobial agents. So circled are the targeted MDROs, which include the pan-resistant organisms, carbapenemase-producing enterococcal bacteria, carbapenemase-producing Pseudomonas species, carbapenemase-producing Acinetobacter baumannii, and the relatively new kid on the block, Candida auris, which is a fungus that acts an awful lot like a bacteria. Some of the endemic MDROs, such as MRSA, VRE, ESBLs, and C. diff, are also really important, but the interventions we're going to be talking about in this presentation will be focused on the targeted MDROs. Colonization is when a resident is carrying an MDRO on or in them, but does not have any signs or symptoms of an infection. It's just hanging out on their body, but it's not making them sick. MDROs are easily shed from colonized individuals, leading to contamination of healthcare personnel hands and clothing, the surrounding equipment, and on the mobile equipment that's going in and out of the rooms. We know that some MDROs can actually persist and spread in the healthcare environment for weeks and maybe even longer. And this can happen when even the individual themselves is no longer in that environment. So even though colonization is generally not a concern for individuals, some residents will go on to develop an active infection. Colonization confers a 2 to 10-fold higher risk of infection with the colonizing organism. So take a look at the picture of the iceberg. For every individual identified with an MDRO infection, there are many more who are colonized. The tip of the iceberg that we can see represents people that we know are infected with an MDRO, and the huge part of the iceberg that's underwater that we can't see represents those who are colonized with an MDRO that we don't even know about. To help visualize how common MDROs are in nursing homes, this slide shows data from a large study that was conducted in nursing homes, including a subset of nursing homes, the ventilator-capable nursing homes. In the middle column are the percentage of residents who had documentation in their medical record of the presence of an MDRO colonization or infection. So about 2 out of every 10 residents across all these nursing homes were already known to have an MDRO, and that also includes endemic MDROs. During the study, all of the nursing home residents were tested to see if they were colonized with an MDRO. The third column shows the percentages of residents who had an MDRO after testing was complete. As you can see in the nursing homes that did not provide ventilator care, almost 6 out of every 10 residents were found to have an MDRO, and in the ventilator-capable nursing homes, the number went up to almost 8 out of every 10 residents. So in a regular nursing home that has 100 residents, this is about the same as having 60% of those residents with an MDRO. And the percentage goes up to about 80% in a ventilator-capable nursing home. What this data and other data like it shows is that there are many nursing home residents who are colonized with MDROs, and we're not even aware of most of them. So as you can see on the slide, Michigan continues to see CP/CRE cases regularly reported, and most of these cases are in Southeast Michigan. This EPI curve shows the number of CP/CRE cases reported to MDSS from 2018 to year to date. So what's going on with Candida auris in Michigan? So as about 2 weeks ago, we have had a total of 217 cases of Candida auris that have been detected and reported to public health since our very first case was detected in May of 2021. Over the last several months, we have definitely been seeing more cases of Candida auris. 152, or about 70% of our Candida auris cases were individuals who were detected positive for Candida auris based on a colonization screening test, meaning they were either high risk for Candida auris or they were in contact with someone who might have had Candida auris, so they were also screened. That's the majority of the cases that we're seeing right now. About 30% of the cases were detected on clinical cultures, so these were cultures normally collected in the process of providing care. And that would include things like urine cultures, wound cultures, respiratory cultures, etc. And 25 of those clinical cases were detected in individuals who were first detected on a screening test, but who later had a clinical culture that was positive. And when we look at the location of healthcare facilities where the specimen was collected and was positive for Candida auris, we can see that all of our cases so far have been detected in Southeast Michigan. 87% of Michigan Candida auris cases have been detected at healthcare facilities in the city of Detroit, and the rest of the cases were detected in other counties in Southeast Michigan. Nursing home residents have a higher chance of becoming colonized or infected with an MDRO due to the following risk factors: indwelling medical devices such as ventilators, urinary catheters, feeding tubes, and central lines, the presence of large chronic wounds like decubitus ulcers, frequent antibiotic use, recent healthcare exposures such as admissions to acute care facilities, long-term acute care hospitals, long-term care, and receiving medical care outside of the United States, complex comorbid conditions, and functional or cognitive deficits requiring a high level of dependence with activities of daily living. So when we talk about enhanced barrier precautions, we will be focusing on those first 2 risk factors: indwelling devices and the wounds, decubitus ulcers. The use of enhanced barrier precautions or any other precautions should be incorporated with several other good infection prevention practices including hand hygiene, environmental cleaning and disinfection, PPE use, auditing and feedback, and communication about residents with MDROs, both within your facility and outside of your facility. So let's take a closer look at each of these prevention strategies. We all know how important hand hygiene is in healthcare settings. It helps protect both the healthcare personnel and the residents or patients by preventing the spread of germs. It's estimated that some healthcare personnel may need to clean their hands as many as 100 times during their shift. And it's a challenge to make sure that staff are knowledgeable about how to clean their hands and when their hands should be cleaned. Alcohol-based hand sanitizer, or APIC, is the preferred method to clean hands in most clinical situations. APIC is recommended prior to and after performing any hands-on activity with the resident or contact with the resident's environment. And this also includes before putting on gloves and taking gloves off. The use of soap and water is recommended if hands are visibly soiled before eating and after using the restroom. And don't forget to assist your residents with their own hand hygiene. Effective cleaning and disinfection plays a huge role in infection prevention by helping to reduce the spread of MDROs, because MDROs can contaminate and persist in healthcare environments. We want to be thinking about creating a cleaning and disinfection plan for our environmental surfaces. One thing to think about is the workflow in which cleaning and disinfection happens, going from clean to dirty, working from the outside in toward the resident zone, and going from high to low because things drop down. Try to clean MDRO positive resident rooms last as a way to try to minimize potential cross-contamination from positive surfaces to negative. Clean and disinfect high-touch surfaces such as handrails, doorknobs, and call lights frequently, but at least daily. And try to streamline the number of cleaning and disinfection products in use in the facility. Having many different products can cause confusion about what to use and when to use them. And keep in mind that many EPA registered products can do both cleaning and disinfection and allow that separate cleaning step to be removed, making the process a little easier. And one thing that we've seen when we're on site in facilities is that there are many different products in EVS cleaning carts. And when we ask EVS staff like what they're all used for, staff is sometimes not sure what the product should be used on and when it should be used. Clean and disinfect reusable medical equipment after every use. Contaminated equipment is considered a major driver of many MDRO outbreaks. Think about creating a who cleans what list, and because we know how easily some MDROs can spread on the surface and on mobile equipment, I want to spend a little bit of time talking about this list. So all healthcare personnel providing patient care should be trained on which mobile and reusable equipment they are responsible for cleaning and disinfecting and how to clean and disinfect that equipment properly. Numerous CDC and health department investigations have found that healthcare personnel are often unclear on who is responsible for cleaning mobile or reusable equipment and even how it should be cleaned. So it can be really helpful to use a tool such as the one shown on the slide to make a list of all of your high-touch surfaces and the equipment that's being used between residents. For each item listed, indicate how often it should be cleaned, what products will be used, especially if it's different than your routine products, and assign who will be responsible for cleaning and disinfection, because it's not always environmental services that will have that responsibility. Once you've mapped this all out, make sure you share it with all of your healthcare personnel so they understand what they are supposed to be doing. And this can be shared with your new staff during onboarding and can also be used as a reminder and used for retraining purposes for your veteran healthcare personnel. All right, be sure that staff knows what PPE to use, when to use it, and how to safely put it on and take it off. PPE should be accessible. Do your staff know where to get more PPE? Can staff access the PPE during the off shifts? Is PPE stored in a cart at the far end of the hallway, away from the resident room? Because if PPE is not readily available, staff may not seek it out to use it. We've been on site and watched staff enter rooms without PPE because the PPE cart was way down the hall and they were not going to make that trek to go get it. So make it as easy as possible for your staff to use PPE. Let's talk about communication. Make sure the precaution signage your facility uses is appropriate and easy to understand. Signage should include all the PPE and infection prevention precautions required for the resident. Using a stop, see the nurse sign is not recommended, as staff and visitors won't know what type of precautions are needed before entering the room. We've actually seen this in a couple of facilities where both visitors and staff totally disregarded that stop sign and walked right into the room without the proper PPE. And keeping a current list of all of your residents who meet criteria for precautions is really helpful, as this information is needed not only by your staff, but any healthcare facilities that may need to provide care for the resident, such as a hospital or doctor's office, and also for your traveling staff, such as podiatry and dental. And don't forget about including everyone on your care team, such as admissions, leadership, case management, EVS, therapy, your frontline clinical staff, and your transporters and EMS. Knowing the MDRO status allows others to take the appropriate precautions. And when we're thinking about discharging a resident with an MDRO to another facility, we need to ensure we are clearly stating what the individual's MDRO status is, whether or not it's a current or recent infection, whether or not they tested positive on a colonization screening, or whether their status is pending, either because lab results are not in or because the person still needs to be tested. We need to specify the types of precautions that are indicated for the individual, making sure that the healthcare personnel at the receiving facility also understands. And there are different ways to communicate this information, such as verbal communication at handoffs and report, and written methods such as using an interfacility transfer form. Transfer forms can really assist in fostering important communication during transitions of care about MDRO status and appropriate precautions. And the goal is to standardize your communication methods so that the same information is always shared along with other medical information for these individuals. CDC and MDHHS have some really good examples of transfer forms. Consider printing the transfer form that you choose onto bright colored paper to make it eye-catching. And there is a slide later in this presentation with links to these forms. As for any of our infection prevention and control practices, one of the most powerful things we can do is to make sure we understand how adherence is actually going. This includes ongoing monitoring, especially for hand hygiene, putting on and taking off PPE, and cleaning and disinfection effectiveness. So think about what data you'll need to collect so that you can have a better understanding of what's working well and where missed opportunities are occurring. And when you track this and display this data, you can routinely share back this information with all of your healthcare personnel and your leadership so they also can see what's going well and what's not going well. Make sure you celebrate your successes, because staff will feel empowered to become an active participant in infection prevention in the facility, and they'll know how their role impacts resident care and safety. And because they're the ones doing this work on the front line, it's also a good opportunity to engage healthcare personnel when there are missed opportunities. Try to provide real-time feedback and find out what their barriers are and what they need to be successful. So standard precautions and transmission-based precautions have presented challenges in nursing homes. Residents in skilled nursing facilities are disproportionately affected by MDROs. And as we discussed previously, resident-to-resident pathogen transmission in skilled nursing facilities occurs in part via healthcare personnel who may transiently carry and spread MDROs on their hands or clothing during resident care activities. Residents who are colonized with an MDRO are often not recognized by healthcare personnel based on the available clinical or screening cultures or their medical history. Standard precautions, which apply to the care of all residents, where the use of PPE is based on anticipated exposure to blood and body fluids, may not adequately address MDRO transmission. This is because standard precautions focuses more on a pathogen-specific approach rather than an approach that focuses on resident risk factors that put residents at a higher risk of acquiring an MDRO. Contact precautions are used when pathogen transmission is not completely interrupted by standard precautions alone, but they create challenges for nursing homes trying to balance the use of PPE and room restrictions to prevent MDRO transmission with residents' quality of life. Contact precautions are intended to be time limited, but MDRO carriers are considered to be colonized indefinitely. And there are many negative consequences associated with long-term use of contact precautions, including loneliness, social isolation, and mental health concerns. So let's talk about enhanced barrier precautions now. Enhanced barrier precautions, or EBP, are infection prevention practices that take a risk-based approach to PPE use to reduce the spread of MDROs, and they're used in conjunction with standard precautions. Specifically, enhanced barrier precautions includes the use of a gown and gloves during high contact resident care activities for those residents at an increased risk of colonization with an MDRO. That's because during the high contact resident care activities, the hands and clothing of healthcare personnel can inadvertently become contaminated with MDROs. Enhanced barrier precautions expands the use of PPE beyond those situations in which exposure to blood and body fluids is anticipated. And for enhanced barrier precautions to be successful, it needs to be an integral part of infection prevention and control activities like the things we've already talked about. As discussed previously, age, comorbid conditions, invasive medical devices, frequent antibiotic exposure, and reliance on healthcare personnel in the setting of communal living all serve to increase the risk of nursing home residents becoming colonized or infected with an MDRO. Nursing home residents have become more medically complex, and nursing homes have needed to adapt and improve their infection prevention practices in a way that also facilitates staff adherence. Basing PPE use on the presence of an indwelling device or wound, or for specific tasks, may be easier for staff to understand and incorporate into their workflow. Using enhanced barrier precautions reduces the need for contact precautions, which have many negative consequences for the residents. And enhanced barrier precautions is an effective response to antimicrobial resistance in nursing homes. So the goal is to decrease infections, which decreases antimicrobials being prescribed, thus decreasing the risk of resistance. High contact resident care activities include dressing, bathing and showering, transferring, providing hygiene, changing linens, changing briefs or assisting with toileting, device care or use of a device such as like central lines, urinary catheters, feeding tubes, trachs and vents, and wound care, which is any skin opening requiring a dressing. Note that this refers to large chronic wounds, which include but are not limited to unhealed surgical wounds, pressure wounds, and chronic venous ulcers. It doesn't apply to small wounds or skin tears that can be covered with a Band-Aid or a small dressing. CDC chose these high contact resident care activities based on hundreds of observations of care in nursing homes. Those activities that are listed on the slide demonstrated the highest risk for transfer of MDROs to the hands and clothing of healthcare personnel. And these high contact resident care activities are usually bundled together as part of AM and PM care, and they're generally performed in the resident room. And just a reminder that physical or occupational therapists should use gowns and gloves when working with residents on enhanced barrier precautions in the therapy gym or in the resident's room if they anticipate close physical contact while assisting with transfers, mobility, or any high contact activity. Enhanced barrier precautions should be used with residents with any of the following: infection or colonization with an MDRO when contact precautions do not apply, wounds, and indwelling medical devices. Again, the residents with those risk factors are at a greater risk of acquiring an MDRO. In enhanced barrier precautions, PPE does not need to be worn for every single resident or every single activity. The goal of EBP is to protect the most vulnerable nursing home residents during the most high-risk activities to reduce spread of MDROs throughout the entire facility. And enhanced barrier precautions is not limited to outbreaks or to specific MDROs. So what does it mean by when contact precautions do not apply? We mean that there are situations that contact precautions should be used instead of enhanced barrier precautions, such as any residents colonized or infected with an MDRO who also have draining wounds, secretions or excretions that cannot be covered or contained, acute diarrhea, and for other infections or conditions for which contact precautions is recommended. Enhanced barrier precautions should be used for CDC's targeted MDROs, such as pan-resistant organisms and those organisms that have no current treatment options or limited treatment options, such as those listed on the slide. CDC's updated guidance now provides facilities the flexibility to implement enhanced barrier precautions for residents colonized or infected with any epidemiologically important MDRO, which are also listed on the slide. So for enhanced barrier precautions, again, gowns and gloves are recommended to be used during those high contact resident care activities, such as what's done during AM and PM care that we've already talked about. Single resident rooms are not required, but if a facility has capacity or availability, a single room may be preferred. In addition, when it's appropriate, residents with the same MDRO could be cohorted together in the same room. Facilities could consider having a designated unit or part of a unit that could be used to cohort individuals with like precautions. This helps with dedicating staff to care for positive individuals and cohorting shared medical equipment as well. If residents are placed into shared rooms, try to implement strategies to help minimize transmission of pathogens between roommates, including keeping at least 3 feet between the beds to reduce opportunities for accidental sharing of items between residents, using privacy curtains to limit direct contact, cleaning and disinfecting environmental surfaces on a more frequent schedule, and being sure to change PPE and performing hand hygiene when switching care from one roommate to another. Residents are not restricted to their room and can participate in group activities and communal dining. Just ensure that the resident is wearing clean clothes and has cleaned their hands when leaving their room. Enhanced barrier precautions should be used during the resident's entire stay in the facility if the resident is colonized or infected with an MDRO. For residents who are only under enhanced barrier precautions due to an indwelling medical device or the presence of a wound, enhanced barrier precautions may be removed when they no longer have the device or the wound heals. And enhanced barrier precautions are only utilized in nursing homes at this time. Okay, this slide breaks down the differences between enhanced barrier precautions and contact precautions. So in contact precautions, gowns and gloves are used for all room entries and for all activities. Private room is ideal. Residents are restricted to their room except for medically necessary care, and they are recommended to be time limited. For enhanced barrier precautions, gowns and gloves are used for high contact resident care activities. Private room is not required. Residents are not restricted to their room and may participate in communal activities, and it is recommended for the duration of their stay. So when you're getting ready to roll out enhanced barrier precautions in your facility, consider developing an implementation plan to help guide you along this process. Your first step is to initiate leadership and staff buy-in. Getting leadership support at both the corporate and facility level is vital for successful implementation of enhanced barrier precautions. Leadership and staff need to know what EBP are, why it's important, and what the impact will be. Factors to include when you're discussing EBP are the benefits of EBP not only to the residents, but also to the facility through decreased MDRO infections and transfers out to hospitals. You can also explain that colonization pressure is also a really important risk factor for acquiring an MDRO, meaning the higher number of residents in the facility who already have an MDRO, the greater the risk for new admissions to acquire it. When we decrease colonization pressure, we also decrease the risk of MDRO transmission. Controlling the spread of MDROs makes it easier to accept and cohort new admissions. Finally, treating MDRO infections is very costly. A 2017 study by Castle, Wagner, Ferguson, and Handler found that in US nursing homes alone, there were an estimated 1.6 to 3 million HAIs. These HAIs cost between $38 to $137 million for antimicrobial therapy and $637 million to $2 billion for hospitalizations due to infection each year. Traditional methods of introducing a new practice, such as staff in-services, where staff receive education on a new policy and procedure, does not always result in the desired response or outcome. Because enhanced barrier precautions has many parts and pieces, facilities may want to consider a quality-based approach to allow an organized and slower implementation of enhanced barrier precautions. This allows leadership to gain knowledge and learn from each unit enhanced barrier precautions is implemented on. QAPI, or Quality Assurance and Performance Improvement, is a data-driven and proactive approach to quality improvement. Applying a QAPI approach can guide the facility's efforts by focusing on indicators that reflect outcomes of care and quality of life. CDC has a customizable enhanced barrier precautions pre-implementation tool, which is designed to be used as a guide for developing a successful plan for the implementation of EBP in the facility. This tool helps the facility assess their current policies and procedures, processes, and tools regarding PPE, APIC, communication and training, and other factors that may have an impact on successful implementation. So when you're putting together an implementation plan, you're going to want to cover all the facets of enhanced barrier precaution implementation, taking into consideration the topics listed on the slide that I'll go over. So when you're making your plan, decide what unit enhanced barrier precautions will first be implemented on. If you're having trouble deciding, consider implementing on the unit with the most residents who are at greater risk for acquiring an MDRO, such as a ventilator unit. After you decide your first unit, determine the order of the other units, making sure you have a target date for implementing enhanced barrier precautions in the entire facility. You'll need to determine how you will provide training and education to all of your staff, residents, families, and visitors. When looking at your supplies, is it clear who is responsible for ordering supplies and stocking those supplies? Where will you put your signage, PPE carts, ABHS dispensers, and disinfectant wipes? Who will be in charge of identifying residents who meet enhanced barrier precaution criteria, putting this info on a list and keeping the list up to date? Make sure your plan is as detailed as possible. Resident and family education is crucial for successful enhanced barrier precaution implementation. Education should be provided to current residents and at admission for your new residents. You'll want to explain why the resident is now on enhanced barrier precautions when they had previously not been under any precautions, and how it's not going to change the care they're receiving, but it will help keep them safe from infection. Allow and encourage questions. A risk of not providing education or addressing questions and concerns before enhanced barrier precaution implementation is that residents and their families may become upset or worried that maybe they actually have an infection. On CDC's EBP website, there is a customizable letter for residents, their families, and friends that facilities can use when providing education. And there's a little snippet of it on the slide. So let's talk about PPE cart concerns. You want to make sure that personal protective equipment is available at the point of care. PPE can be stored in carts, caddies, or something that's mounted to the wall. Generally, this is placed right outside of the resident room, so healthcare personnel can put on their PPE before entering the room. The placement is dependent upon each individual facility based on their layout and what works best for them. It's not a one-size-fits-all approach. Before implementing enhanced barrier precautions, look at the number of PPE carts your facility currently has, if that's what you're using. You may need more. So if you're choosing new PPE carts, just make sure that whatever you choose is able to hold an adequate supply of PPE, and make sure it's made of a material that can be cleaned and disinfected. Concerns about having too much equipment in the hallway is a legitimate concern. Crowded hallways makes it really difficult for residents and staff to move. So it may not be feasible to have a PPE cart outside of every door. You could consider spacing them so that one cart can serve 2 to 4 rooms, which works really well when you're able to cohort affected rooms. And when purchasing carts, consider models that are slimmer and have wheels. Many facilities have concerns about violating the life safety code, specifically about projections of equipment into the corridor. This is allowed under the conditions spelled out in the code. Specifically, number 1, equipment cannot reduce the corridor width to less than 5 feet. Number 2, the equipment must be able to be relocated during an emergency. And number 3, wheeled equipment is limited to equipment that's in use. So PPE carts would be included as long as they are in use and have wheels. And as always, access to fire and smoke doors, exits, and emergency equipment cannot be blocked. So one of the most common concerns we hear from facilities when we're on site is that having APIC outside every resident room takes away from the home-like feel because it's the resident's home. We understand this, but facilities also need to do all they can do to keep residents safe, and that includes easy access to APIC. We recommend APIC inside resident rooms as well, especially in multi-resident rooms. But many of our facilities have concerns about surveyors considering this a hazard because of possible inappropriate resident access. However, CMS does support APIC in resident rooms, but facilities do need to be careful with certain populations, such as those in memory care. It's always very useful to conduct a risk assessment when looking at APIC placement in resident rooms. And facilities are sometimes reluctant to increase the number of APIC dispensers in the hallways or to place APIC outside every resident room due to violating the fire code and life safety code. So check with your fire marshal, but generally a facility is not allowed to have more than 10 gallons of fluid in a single smoke compartment, excluding 1 individual dispenser per room. And then for disinfection to occur, disinfectant wipes must be conveniently located. Many facilities keep disinfectant wipes at the nurse's station or locked in the med cart. And we know that if wipes are not conveniently located, equipment and surfaces are probably not getting cleaned and disinfected. We recommend attaching wipes to some reusable equipment like vital sign machines and transfer lifts. And again, we know that if wipes aren't easily accessible, that equipment may not be getting cleaned and disinfected. This is a snippet of the NFPA 101 Life Safety Code requirements for the use of APIC dispensers, which is on the CDC website. It goes over things like alcohol content, maximum dispenser capacity, and APIC dispenser distance from ignition sources. This info can be helpful for facilities who plan to increase APIC dispensers on resident halls. So staff will need a little extra time for putting on and taking off their PPE. Staff workflows will need to incorporate bundling care to avoid having to repeatedly put on and take off PPE during AM and PM care. Using more PPE may generate more trash, so your facility may need to increase trash pickup. And take a look at the size of trash cans in the resident rooms. Some of them are very small and don't hold much trash, let alone the PPE that will need to be removed in the room. Education about enhanced barrier precautions should be provided at orientation, annually, and as needed. Make sure your education is discipline specific for nursing, rehab, and EVS. You may want to develop an MDRO EBP care plan that can be placed in the residence chart or record for your care providers to refer to. And again, creating and maintaining a current list of your residents on enhanced barrier precautions, plus utilizing enhanced barrier precautions signage outside resident doors helps let everyone in the facility know who is on EBP or other precautions. As previously discussed, audits are an important means of noting when additional training is needed in response to lapses in infection prevention practices. For this reason, it's really important to make frequent observations of hand hygiene and PPE use on all shifts. Audits should be job specific and include all disciplines, and don't forget your medical providers. Successful auditing allows for just-in-time training and reinforcement. Be sure to provide prompt and regular feedback on adherence and related outcomes to your staff and leadership. The document shown on the slide is CDC's Enhanced Barrier Precaution Observation Tool, which can be used for healthcare personnel that are using EBP during high contact resident care activities. Okay, this slide lists some really good resources for facilities when implementing enhanced barrier precautions. And I've also included links to some really good transfer forms that can be used when transitioning between the different levels of care. So this slide shows what can happen when multi-drug resistant organisms are in a facility. So we have these individuals who have these organisms. So we need to pay attention to how they might contaminate the environment and healthcare surfaces, how healthcare personnel provide care and how that can lead to contamination of hands and clothing, and how organisms can inadvertently be passed on to the next resident or to the equipment. But by paying attention to when we are doing hand hygiene, when we are wearing gloves and gowns for resident care, making sure we're using a product for cleaning and disinfection that is effective against specific MDROs, we hope that although we might have individuals who are positive for MDROs in our facilities, we can prevent the spread to other vulnerable residents. So I have a scenario for you guys, and I'm going to read it, and then you can just drop your answer in the chat. So Ms. Jones is sent to the hospital for altered mental status and tests positive for an NDM Klebsiella pneumoniae. After a short hospitalization, her condition improves and she's discharged back to your long-term care facility. Which kind of precautions should Ms. Jones be put in? A, contact precautions, B, enhanced barrier precautions, C, contact plus enhanced barrier precautions, or D, no precautions are needed. And I'll have to rely on Kelsey and or Chow to let me know like what comes through.
I got it, Margaret. We'll just give them several seconds to drop their answers in the chat, and then I'll let you know what I see.
Okay.
Margaret, can you please give the definition of NDM?
Oh, well, NDM is the resistant gene. So I wouldn't, it's New Delhi, Metalo, something or other. I can't remember the M part of it, but NDM is the resistant gene that actually makes the carbapenem antibiotics not work. And it's in that gene confers resistance to other types of organisms easily.
Margaret, so far we're seeing majority of answers are B, and I see a couple C and one A.
Okay, the answer is B, enhanced barrier precautions. And because that is a targeted NDM Klebsiella pneumoniae, because of that, the NDM, that is a targeted MDRO, which enhanced barrier precautions would be indicated for. So 2 weeks after Ms. Jones' return, she's feeling much better and has returned to her usual baseline. Is it okay to discontinue enhanced barrier precautions? A, yes, enhanced barrier precautions are not needed when symptoms are absent. B, no, Ms. Jones should stay on enhanced barrier precautions until she tests negative for the organism. Or C, no, Ms. Jones should stay on enhanced barrier precautions for the duration of her admission.
So far, we're seeing C coming in.
That's correct. She should stay on enhanced barrier precautions for the duration of her admission. There's no testing out of this at this time. All right. 1 month after her hospitalization, Ms. Jones develops abdominal pain, fever, and acute diarrhea. She has been on enhanced barrier precautions since her hospitalization. What is the correct course of action? A, she should be switched to contact precautions. B, she should stay on enhanced barrier precautions. Or C, she should be switched to contact precautions And once contact precautions are no longer indicated, she should be switched back to enhanced barrier precautions.
All the answers coming in are C again, Margaret.
Oh, great. Guys are good. That's the correct answer. And the last question. Mr. Smith resides in a room on the same unit, 3 doors down from Ms. Jones in the long-term care facility. Mr. Smith has stage 4 kidney disease and receives dialysis through a central venous catheter. What is the correct reason for placing him on enhanced barrier precautions? A, Mr. Smith is at higher risk for acquisition of an MDRO due to having an indwelling medical device. B, Mr. Smith has to leave the facility regularly for dialysis. Or C, Mr. Smith has a serious comorbidity.
All the answers that are coming in are A.
Excellent. That's the correct answer. Yep, that indwelling medical device is an indication for enhanced barrier precautions. So in summary, shifting to an approach based on resident risk factors may lead to a decrease in MDRO transmission while also upholding the resident's quality of life, comfort, and dignity. The use of enhanced barrier precautions helps provide a balance between resident quality of life and safety from the spread of MDROs. And this is our contact information for SHARP unit and for IPRAT. SHARP, we usually handle the MDRO questions, enhanced barrier, well, not only us, but IPRAT is also a great resource too. They handle a lot of the infection prevention, general infection prevention questions. And we are sister units and we definitely work together. And I am ready for questions if there are any. I'm going to stop sharing my screen here.
Margaret, there was one question in the chat. I'm just scrolling back to it. So this question came from Amy. We have used EBP in my facility for several years now. I wonder about the long-term sustainability. If we end up with 10% of our residents requiring EBP, the prospect of requiring staff to don or doff for the required activities is daunting. Any recommendations?
We hear that and we understand that in some facilities, the percentage of people who are on enhanced barrier precautions is huge. But at this point, it is still the best way for people who are living in your facility to stay safe. And hopefully, I know you've been using it, for a while now. Hopefully it's just becoming part of your processes in caring for your residents. I think we know more about MDROs and this is how we can help prevent them. But yes, we 100% agree. It's a lot of PPE use and there's a lot of donning and doffing. But remember, it's not used for every activity. And I know, although you are using it quite often, it's just for those high contact resident care activities. So it's not quite as onerous as contact precautions. Plus, it does allow your residents to have a better quality of life rather than being stuck on contact precautions. And I hope I answered that question okay for you, Amy.
Another question is from Tammy. There are many concerns about the privacy of our residents with signage on their doors. How is this being addressed in other facilities?
So signage on the doors can lead to perceived stigma or real stigma. And what we have found in facilities are the ones that are able to give education right away to their residents and their families, letting them know about why enhanced barrier precautions are being introduced and why they're being used in the facility can help with that. It's when you go ahead and stick an enhanced barrier precautions signage or put a cart outside someone's door, don't give them the education and allow them to ask questions and talk to their family that we see those issues. So for that type of a situation, we recommend very good education to your residents, your staff, and to their visitors and families, focusing on safety, keeping their loved ones safe.
I don't see any more questions, so I'm just going to go ahead and again, thank you so much, Margaret, for a wonderful presentation today. You covered a lot of grounds in a short period of time, and I know that this was a valuable and very helpful for our audience today, given the increase in Candida aureus cases reported in Michigan. I just want to give some quick APIC Great Lakes updates before we close out. Reminder that the event flyer is posted to the APIC Great Lakes on May 2nd at 1 p.m. with a presentation on how utilizing social media can make you a better IP. And as Kelsey mentioned earlier, we will send out a post-webinar email with a link to our YouTube channel where all these session recordings, including today's session, are posted, as well as a link to where Margaret's slides can be found on our APIC Great Lakes webpage. And when you're on our YouTube channel, don't forget to hit that subscribe button. And one final reminder, if you have any open job postings, please send them our way and we'll be happy to post them to the webpage to help your team with recruitment. And with that, Margaret, I just want to say thank you to you again for your time today, sharing your knowledge and educating us on enhanced barrier precautions so that we can apply what we learned today to prevent MDROs in nursing homes. Thank you. And have a safe spring break.